Hello, and welcome to Project Open's Tuesday Talk. My name is Achil Khan. I'm the director of Project Open, which is a $1 million HRSA grant aimed at addressing substance use and the opioid crisis. It's a $1 million grant with focuses on prevention, treatment, and recovery. Today, we're going to be talking more on the treatment side of things, local efforts, and more importantly for our broader audience, rural efforts to address residential treatment for substance use disorder. I'm very excited to have some key local stakeholders on the phone call today. We have Patrick Phelan, the CEO of Sinisippi, which is a behavioral health provider in Lee, Ogle, Whiteside, and Carroll County. We have Sheriff John Simonton, Lee County Sheriff, who was instrumental in starting a police deflection program, which he's excited to share today. And we also have Christy Guile, the Chief Nursing Officer of CGH Medical Center, located in Sterling, Illinois. Hi, guys. Welcome.
Hi.
Thank you for having us.
So I'm going to kick it off to you, Patrick, to kind of give us a definition of what residential treatment for substance use disorder means.
Thanks, Akil. There are different levels of treatment in which a person goes and spends the night somewhere, right? So, when we talk about residential treatment, people sometimes think is that, a detox program where you go and you just get past those medical symptoms of needing a drug or a drink. Is that a long-term, we hear about the 28, 30-day program, that's where somebody goes off and attends those groups and individual sessions and helps them to maintain their sobriety. Also, locally, we've, in the last couple of years, opened some recovery homes, which are longer-term, recovery-oriented residences that are a next step. And so when we talk about residential treatment, today we're talking about a couple of different levels of treatment. We're going to talk some about detox, which is a very time-limited, acute treatment for certain kinds of addictions, especially when we're talking about opioids or alcohol. And that's, you go in for a few days and they're going to medically make sure that you're going to be okay. You're not going to have seizures. You're not going to have problems from the withdrawal from that medication or from that substance or whatever it is, that you've come in because you're using. The other thing that we're going to talk about is what we tend to call residential treatment. And that's that traditional 28-day program where you're going and staying someplace where there's intensive group and individual services, but you're not usually at that place where you might have medical repercussions from your drug or alcohol use. And so at times we'll talk about going from detox to residential treatment. And then, of course, those other sober living options in the community, which could be much more long-term. So we'll try to stay standardized with our terms. We'll talk about detox, we'll talk about residential, and we'll talk about recovery homes or sober living.
Thank you for that definition, Patrick. It's very important that we align on kind of the language in our topic today. Christy, I want to pass the ball over to you and kind of, for our viewers and listeners today, why is this important? Why is this topic important to you and others?
Sure. And I know that the Lee County and Ogle County related data looks somewhat similar to Whiteside, but Whiteside County completed their, every other year we do a healthier communities assessment, needs assessment for community health. And we found that in the data that comes from the Illinois Department of Public Health, as well as the National Center for Health Services, that drug and alcohol and opioid related deaths continue to be on the rise, not only in Whiteside County, but also in the state of Illinois. And one of the things that was the most profound piece of data for me in the most recent results that we received is that, between 2009 and 2018, drug overdose deaths by age group, it's the highest rate of death between 35 and 44-year-olds. And the next age group where this is a high death rate is between 25 and 34-year-olds. So that's a large population base of young people in our communities that are passing away related to what could be preventable drug and overdose related deaths. And it's really a high priority for us to address this now and to lower those rates because they're continue to be on the rise. And I realize our data is from 2019 or 2009 to 2018. We know post-COVID, those rates are only growing.
I think you're right on that statement over there. We were seeing a tapering off, I think, from 17, 18, but going into COVID, substance use and everything went on the rise, which is why this topic has become more and more important. But again, this topic has been around for a while. We have data from 2009. There's a lot of efforts that have happened historically that have brought us to this point. Sheriff Simonton, would you mind, again, sharing why this topic might be important to you, and then moving on to what's been done so far?
Well, just to dovetail on what Christy said, we started a group called PRISM of Lee County back in early 2015 as the unfortunate result of 5 young adult deaths in Lee County. Our county population is about 35,829 square miles, so it's not a heavily populated area. So when you have 5 young adult deaths like that in a small population, most everybody knows everybody in this county, and that hits us hard. And as a result of that, we formed PRISM, which is Prevention, Recovery, Information on Substance Abuse and Mental Health, with a group of stakeholders involving the State's Attorney's Office, all law enforcement in Lee County, Sinisippi, KSB, the Health Department, and also a grassroots group called Safe Harbor, which are community members that are certainly interested in helping those that are afflicted with substance abuse and mental health. And some of those also are recovering. And so it's a great group of people to get together and start to talk about what we can do to make a difference in our community and to stop these deaths from happening and the overdose that were occurring in our area. So again, we were just getting started. And so we wanted to find out what kind of programs were out there, so that we could move ahead with trying to help some of these folks. And lo and behold, a lot of these members are good on the internet, and they found a program that was started in Gloucester, Massachusetts by Chief Campanello, law enforcement initiated, the only one we could find in the nation at the time. It's called the Angel Program. And what the chief was doing at the time was very innovative, something I hadn't heard of. I don't think anybody else did at the time, but he was having the same kind of problem in his community. And what they started was that those that had a substance abuse problem and they wanted some help, he allowed them to bring their drugs in. If they were willing to get some help, they would bring their drugs into the police department, and he or his officers would then get them to a treatment center within 1 to 2 hours so they could start their treatment process. So the important thing for him was to get with the state's attorney right away to make sure that, number one, we weren't going to charge somebody coming into the police department with drugs, because that's historically what we would do. And nobody would bring their drugs into the police department. Secondly, they had to develop a certain amount of trust that would happen. And then thirdly, and most importantly, get into treatment right away, because if somebody's willing to go through that process, which I'm sure is very difficult, I don't have a personal experience with that, but I've seen this happen. You want to get them in right away. So we had treatment centers already on board, and his program became widely successful. So we just did what we could to try to copy what he did. We got on the phone with him several times to figure out how he initiated his program. One of the important things for us is we don't have a lot of those type of treatment centers close by. So we had to personally visit a lot of the treatment centers in northern and central Illinois, and maybe some of the surrounding states as well, to help them understand what we were trying to do. And lo and behold, they were very, very willing to help us. I then and Chief Howell from Dixon PD were engaged with the state's attorney's office. We told them what we wanted to do. They were very much in favor of us going with the same program as the Angel Program, allowing those folks that would call to bring in their drugs. We would dispose of them and start the screening process and get them to treatment as quickly as we could. The most important thing was trying to get them to treatment quickly. And lo and behold, when we kicked this off the first part of September, I believe it was, we had 8 people initially come into our program. We were able to get them into treatment within 1 to 2 hours. And after that, it took off very quickly. And I think by the end of the year, we had probably 30 in treatment, just that first quarter of the year. So it was, we had a lot of smiles on our face, smiles not because of the amount of people that certainly were afflicted with substance abuse at that time, but those that we were actually helping. A little bit of background on me. I'm a 40-year law enforcement officer with 4 different agencies, and I was brought up on the concept of the war on drugs, and we did nothing but enforcement. There was no assistance like this early on in my career. We never thought about anything like this. It was just bringing people to jail and getting them off our streets and serving the public and making the public and the motorists much safer by doing that. But what we were seeing is a very high recidivism rate. At one time, I think I remember arresting a grandfather, a father, and a son of the same family. We weren't stopping this from happening, and I was seeing the same people coming in and out of our jail all the time. So I finally saw the light as well when we were talking to Chief Campanello and other folks in PRISM that we had to do something different. And different was what we formed was Safe Passage. And we've seen an incredible response to this. The deputies and officers that are involved in this as well developed a great amount of trust from those folks that wanted to get some help. And the treatment center providers and all the other stakeholders involved in this were extremely helpful and educated me and brought me on board. And it's been a wonderful program. So I'm glad we got it started, but we got a lot of work to do yet. And I know Patrick and all of us on this program will talk about what we need to do yet. But along with the Safe Passage program, we did a lot of other things with PRISM as far as getting some focus groups together and forums. And we had a Dare to Know program here in our community. We brought Tim Ryan in, Man in Recovery, his Dope to Hope programs, which he's done at a lot of our schools in Lee County, and talking with more treatment providers and trying to get our folks into more treatment. We set up 4 pillars of prevention, education, treatment, and enforcement. Law enforcement side of enforcement, we were doing that really well, but we weren't doing the prevention, education, and treatment part very well. So we were learning about those pillars as well. And we know that we have a place in there to help out. So it was very educational for me, and it was just a program that I'm very proud of today.
Thanks a lot for that background, Sheriff Simonton. A lot of work has been done to the point. We've got our area. Our grant is a national. It's a federal grant, and we have stakeholders from all over the country. We work together on ideas. And when we've shared some of the history and progress that's happened in our area locally, a lot of people are just floored. Many other communities are years behind us. If not, they're not even there yet. And so, kudos to your deputies and your departments and the law enforcement agency for being very progressive in our area and bringing the Safe Passage program years ahead of its time. And we're excited that program's continue to expand in our area. But you had said something early on that was said, the most important thing was getting someone to treatment. And as Patrick mentioned earlier, there's a lot of different things we're talking about today, right? There's different levels to it. So Christy, I was hoping that you'd be able to maybe help us kind of understand some of the workflow for someone in need of services that we're, for the population we're talking about today.
Sure. And I'm going to take an approach of a couple different paths that they might take to treatment. The first is the acute care route of, gosh, we don't even know that there's a problem. So, for instance, and this is a story that I share that really drove our organization into developing evidence-based protocols to help with withdrawals, both from alcohol and/or opioids. A patient comes in with an infection of some sort. They're coming through the emergency room. Everything looks fine, short of the fact that they're going to need to be on some antibiotics for a few days. You get 24 hours or so into the hospitalization, and the patient is starting to show signs of withdrawal. And that's when we find out, oh, geez, something's going on here. And then the patient leaves against medical advice because they do have an addiction and they have a need, and they need to fill that need. And then they bounce back to the emergency room again once they're feeling better. So we had one individual in particular that bounced back significantly like this for several days, actually over the course of about 10 days. And really what the outcry was after that visit or after that experience was from the nursing staff and the physicians going, we need a protocol, because it wasn't in that individual's best interest to jump back and forth. And so we created, using evidence-based practice tools, an opioid withdrawal scale. And in that circumstance, when someone is admitted to the hospital, and we're not unusual, this is standard practice almost anymore, we do these assessments to determine what's the symptomology, what are the things that our patients are showing us that show us that they need some help. And based upon that score, then we can help provide, I guess you could say, bridging related treatments and care, both medication assisted as well as with environmental related care that's more holistic, to help provide the medical care they need for the acute medical concern, as well as help get them through withdrawal. And then after that withdrawal time frame, we can keep them stabilized and safe, and then help with the referral process, whether through safe passages or through our social services referrals, to get them to more of a residential related or inpatient rehab. Those are the circumstances that we come across more often, which is someone presents to our emergency room for admission related to something completely different, and we trip over the fact that they're going through withdrawal. We have similar protocols now also for alcohol withdrawal. And interestingly enough, those protocols were in place for a few years before we started realizing we also need it for opioid withdrawal. It's just, you can see the shift over the past several years between alcohol withdrawal and then the increased incidence of other medication-related addictions. So the other component that we have also experienced is someone that does want to receive treatment, and they're looking for that inpatient residential or something more long-term, but they need to detox first. And that's the important piece for them, is to maintain that safety for that individual while they are getting ready to go to some place for more permanent long-term assistance in recovery. So, for those of you that aren't familiar with this, withdrawal symptoms, especially in severe cases, can be life-threatening. And it's really, really important for the safety of that individual to seek medical care to ensure that we don't have issues related to heart arrhythmias, seizure activity, other things that could really go badly if you're trying to detox on your own. And that's where we've come in and helped out to help bridge those individuals in the community so that they are ready and their body has gotten rid of those toxins so that they can safely move into the next phase of their recovery. Again, we utilize the same withdrawal scales and the same treatment until they're ready to move to the next phase. And I can think of 4 or 5 different good stories that either of individuals that came in acutely for other related medical issues, or unfortunately, perhaps they overdosed. And again, we bridged them through that medical concern and stabilized them until they were ready to go for something more formal related to recovery. And then finally, we've had individuals that were on the path to going to a facility and found out last minute, oh shoot, no, they're not going to accept me unless I've been detoxed for 3 days. And we bridge them, we bring them in. Last but not least, something that we do here at CGH that's been a really nice partnership with the Whiteside County Health Department is individuals that present to our emergency room on the weekends or times when the health department isn't open, and they are seeking a bridge to their medication assistance treatment program, or their MAT program, where we can provide some assistance over the weekend to provide them medication assistance until they can get formally into the MAT program at Whiteside County Health Department. And that's been really helpful. Now, is it widely used? And are we getting 10 people per weekend? No, that's not the case. But when individuals do present, we do have mechanisms and a structure in place to assist with it, even though we don't advertise that we have a formal detox program. It's interesting because it's just because it's part of the care that we provide, that we created that infrastructure because it's mission driven. It's important to our community that we ensure their medical stability until they're ready to go to recovery. And in which case, then we can reach out to Safe Passages or Sinisippi or one of our other partners within the Project Open family to assist with that happening. It's one of those situations where when it all comes together, it's so fulfilling. And it makes us all proud of what we're doing, because honestly, that's why many of us got into healthcare. And, then to see those individuals, maybe 3-6 months down the road and they're still successful, it's just, you kind of want to high five each other for it. So that's kind of the acute care path. I know there's 3 or 4 buckets, but essentially it's all the same. It's just the approach might be different depending on how they present to the hospital.
Thank you for that background, Christy. We have a saying in healthcare, there's no wrong door, right? We want to make sure that every door that someone comes in through, they're able to get access to the care. And so Sheriff Simonton shared his door, right? Someone can come in and turn in their drugs and paraphernalia and get placed into the appropriate level of care based off an evaluation. Patrick, I wanted to pass it to you to see kind of what your part of the workflow is traditionally when we're talking about residential treatment.
Thank you. Yeah, it's interesting, and I really appreciate Christy and Sheriff Simonton talking about their interactions with individuals struggling with addictions, because often ours is not the first door here at Mississippi Centers that they come through. Individuals may find themselves in the ER, or sadly may find themselves, in contact with law enforcement when they're really in need of treatment. And so, when we traditionally got referrals, they came 2 different ways. They came either from a probation officer or a court who was mandating treatment for somebody, or that individual who says, I really need to get some help. I'm going to call Mississippi Centers and see what they can do for me. This partnership has created so many more avenues to get people into treatment. And so it's been wonderful. And on the outpatient treatment side, that's worked fantastic. A couple of years ago, when we were talking about what are the gaps in our continuum of care, we identified, amongst other things, those 3 areas of, we'll call them, overnight stay kinds of treatment. Detox, and Christy was talking quite a bit about that, the residential treatment that we referenced earlier, and recovery homes. And so what we were sitting around the table with PRISM and all of these other providers, and everybody is so passionate. And so I came back to my office and I called what was called at the time the Illinois Department of Division of Alcohol and Substance Abuse, and said, okay, we need residential detox and recovery homes in our area. We're going to do them all. Tell me how to do it. Let's give me the funding. Let's just go. And of course, it's not that easy. And we've taken some bites from that. From that conversation, what we really took away was that, as Christy mentioned, the hospitals are already doing detox to some degree. And so following that, we've entered into conversations with CGH as well as KSB hospitals and said, okay, you guys are doing some detox informally already. How do we make the most of that? How do we utilize that in our continuum of care? And then we said, okay, now we really need sober living. We're able to take somebody, if we have to Rockford, to Chicago, to Peoria for that residential treatment, but we have no idea, what happens when they come back to our community. If they go back to the same places and the same people where they were using and with whom they were using, that's not going to be great for long-term sobriety. We need sober housing. And so that led to the opening of our 2 recovery homes, one in 2018 for men, and then one just last year in 2020 for ladies. I don't know if we've met that need fully going forward. There may be more in the future. We'll see as that need ebbs and flows. What we haven't done, and there are a few reasons for this, is to open up that sort of traditional 28 or 30-day residential treatment program that's often the next step after detox and the step before those recovery homes, where that intensive therapeutic work gets done. And so that really, as we've looked at the continuum, we've been able to address the different pieces. We're still working on detox. We don't know if we've got enough recovery home beds to meet the needs of our community yet, but that piece in the middle, that 28-day traditional treatment program, we haven't quite gotten there. And there's quite a few different reasons for that.
No, thank you. Thanks a lot, Patrick. And I think now it's appropriate to kind of, if you guys are okay with it, kind of start to shift to identifying that need. So we know that these centers exist, but where are they? You know, Sheriff Simonton, Safe Passage has been placing people into treatment. I'm not sure if you have a rough idea of how many, just so we can begin to quantify the need. Because what we really want to convey to our viewers today is, we know this is a need, but there have been barriers and challenges to bringing it here locally. Patrick, you've hinted at some of those right now, but maybe we could start with defining that need a little bit more, starting with maybe where are some of these exist, right? So where are they?
Akil, if I could, I'd like to add something to what Patrick and Christy were saying as well. When you're talking about all the programs that we've kind of got started and what we've identified, when I first started talking about Safe Passage, we thought we had it at that point in time. Okay, we've got people coming in, we've got them to treatment, and you kind of sit back and good. We just met a good project, a really good goal right there. And then we started realizing we're not even close to being done. This is such a multifaceted approach, and everybody that's been part of this program has been, working their tail off to try to figure out what else we need for when those folks have gone through the treatment and they come back to the community. Like Patrick said, we want to help them educate themselves more, going through groups of people that have gone through this, what their recovery is going to look like long term, try to help them get some gainful employment so they can be financially independent and get back with their families. And of course, Patrick talked a little bit about the recovery home. So, from a law enforcement perspective, how can we help with this multifaceted approach, knowing that some people are still going to be incarcerated? They're still going to come to my jail. So how do I help them when they're here? So it's not necessarily the best place to go through withdrawals, but unfortunately, you're not going to get drugs or alcohol or whatever else it is in our facility. So what we've done here is we've increased the hours of our jail nurse to help with some, medical treatment while they're going through withdrawals. We've partnered with Mississippi, and Patrick has his counselors come in for those that are afflicted with mental health disorder, and they come in quite frequently to our facility. We've got that type of counseling going on. We also have faith-based counseling going on in our facility. We have Vivitrol available, Narcan as well, and trying to do some things within our facility to help because I've seen the deterioration in our facility before. Early on when we started this program, and I know I've talked to Patrick several times about certain individuals that have been in here, and certainly KSB Hospital, that while they're awaiting their court trial or sentencing, they're deteriorating in our facility, and there's nothing I can do about it. It's a sad, sad situation. So we want to avoid that from happening. So by having some of these other programs available within our facility, maybe we can get ahead of that, and we have shown to do that. In addition, we formed a crisis intervention team or crisis prevention team that kind of mimics Safe Passage, but it's more on the mental health side, where we can be a little bit more proactive and identify those folks in our communities that we may come in contact with first. Like Patrick said, they might not be the first ones that will see these folks. It might be us. We might be familiar with them. So how do we approach them? And we send our officers and deputies through the crisis intervention training, have them part of this program so that they can better communicate with these individuals and maybe even be more proactive and visit them before they have any type of episodes and just see how they're doing. And overall, it just develops that trust and that communication. And it's one of those things where we're trying to be a little bit more proactive, I think is what I'm trying to say.
I think, across the nation, we're starting to see some innovative programs where they're shifting from crisis intervention to crisis prevention. And I think that's what you just nailed on over there. There's a program in Denver, Colorado, where to anything that's substance use related, that's not a violent situation, they send a paramedic and a social worker with law enforcement near backup. And so some of this, what you just mentioned over there, Sheriff, this is some of the stuff on the cutting edge. I'm going to just open it up to group discussion again to help kind of frame the need for our area, especially here in rural America, and then maybe get to, what are the barriers to getting a residential treatment in our area?
I'm just gonna jump in real quick, Akil, and talk about some of the barriers we see when we're trying to help someone into the next phase. Generally speaking, and again, if you just Google inpatient treatment programs, the first thing that's going to pop up on that screen, and we experience this in our social services department as well, is the first question is, what's your insurance? And I think one of the biggest challenges we have currently is that the population that we're really truly trying to help is challenged with that. We have the ability to make some referrals into inpatient recovery centers and inpatient rehabs if their payer is what works for that organization or that facility. And that's one of the biggest challenges we see. Additionally, we have an opportunity in our region to really try to find providers in our region that want to be certified or engaged in working with patients that need long-term medication-assisted treatment. It is a specialty and it requires additional education, and that's another challenge for us in a rural setting, because it's challenging for us to recruit physicians to begin with and providers to begin with. You add that level of specialty to it in a subgroup that they're not as familiar or comfortable with. That is another barrier for us.
And Christy, that when we talk about payment and the payer source, that's one of the challenges that we always run into, is that a private insurance carrier might pay 2, 3, 4, 5 times or more what Medicaid or the state grant funding to support those who aren't insured will pay. And so inpatient residential substance use providers find themselves with sort of doing that balancing act between, there's a need amongst these groups, but we can't dedicate all the beds to them because we've got to be able to pay the bills and keep the doors open. And so we've got to look at ratios between payers, Medicaid, private insurance. And so that is, it's always one of the biggest challenges. The other challenge that we've run into locally, and we have some great partners out there who do some great work, and we've referred lots of people over time to places like LSSI over near Chicago, or Rosecrans in Rockford, or Human Service Center in Peoria, and those Chestnut down in the Bloomington Normal area, fantastic providers, fantastic partners. But somebody comes in and you've got about 5 minutes at times of willingness. They've said, okay, I am ready at this moment to get clean and sober. That may not last for days. You can't say to them, okay, come back in 2 weeks because we got a bed for you somewhere. You've got a window right there, and you've got to take advantage of that window. And so, if we have to look all around the state for open beds, ultimately we transport them to Bloomington Normal for detox. They're there a couple days, but there's not a treatment bed there, and so we got to go get them. And then the treatment bed is available in Chicago, and so we take them there, and then we're bringing them back. It really takes a lot of coordination. And each one of those transitions of care, you have the opportunity to lose somebody, and to lose them from that path of sobriety. So that's those, I think, when we talk about the payer and then just sort of the geography, are for me the two biggest challenges.
Yeah.
So, Patrick, you mentioned right now these centers are located to more urban areas. You said there's some in the Chicago suburbs, Rockford, Quad Cities, Bloomington, and through the Safe Passage program and a new local organization, a recovery community organization known as Sauk Valley Voices of Recovery, they've been able to do peer support and get people placed into treatment. They are kind of a bridge or a Band-Aid to the issue of care coordination, but they don't, it doesn't really fix that issue of when we send someone out of our area and they come back, a lot can happen and a lot's changed. So you started to talk about the Medicaid population and the reimbursement. Has any analysis been done to, if we were to have a center, how would we staff it? How many beds would it be? Where would it be? And how much money would this make or lose?
Gil, we've been looking at this for several years, and what we do see is that people with private insurance have options, and they can generally get to Rockford or Peoria or Chicago or wherever they need to go. Not always, but generally. And so for those locally that have the greatest need for a center right here in the Sauk Valley area, or those folks who are funded by Medicaid or may not have insurance, the challenge, and there's a couple challenges with that. As I said, one of them is balancing those lower rates and being able to sustain a center without that private insurance population. And so we're looking at who are we really trying to serve and who desperately needs the help in our area and can't get it elsewhere. And will that ultimately pay the bills if individuals with Medicaid or without funding are, essentially taking up, or not taking up, but essentially filling all of the beds in the center. And what we know is, just running some basic numbers, that kind of a scenario is just not financially sustainable if all of those beds are filled with folks who don't have private insurance, that great luxury that so many of us take for granted. So in that kind of a scenario, we lose probably on a 15 to 16 bed, maybe only $300,000 to $500,000 a year, but it's a barrier that's been insurmountable in recent years. The other option, obviously, is to try to draw in regionally more folks with private insurance, but then you run the risk of not having beds for local individuals who have a need. And then all of a sudden we've got people from Chicago here in our center, and so we're having to send our neighbors that are coming in to us for help down to Bloomington or Rockford or wherever. So there's a lot of challenges around that funding mix and being able to meet the needs of who we need to serve. There's also something in the law that's called the IMD exclusion. And what the IMD exclusion says is that if you have more than 15 people with Medicaid in a setting of whatever kind, a residential setting, that's an institute of mental disease, and Medicaid can't pay for services in an institute of mental disease. So you can't build a facility that's more than those 15 beds and serve all individuals with Medicaid, because then you're an IMD and then Medicaid can't pay for those services. There's been some work done by the state of Illinois to work with the feds to get some exclusions to that, some overrides to that IMD exclusion, so that we could potentially look at bigger centers, but they're not really granting those exclusions to providers yet. The challenge here is that if you're going to build to the scale that's going to be sustainable, 15 beds isn't sometimes enough to support things like psychiatric care that you need, 24-hour staffing, all of the other costs. Maybe 30 beds is a sweet spot that can support that. And so that IMD exclusion is one of our other challenges that we'll need to overcome, or at least work within, if we're going to do something locally.
There might be some people screaming at their screen right now, like, well, why can't the hospitals do it? Why can't we put it inside the hospital? Christy, do you have any comment to the feasibility of that?
So one of the challenges that we had, and it's something that could potentially be overcome, but requires a little bit more research as well, and some discussions probably with the different agencies in the partnership. But for instance, when we opened the behavioral health unit, we had to go to the state of Illinois Certificate of Need board and justify the fact that we needed a 10-bed unit. When the state assessment, what people don't realize is the state does an annual assessment of beds and how beds get designated. And at the time when we made the request, they said that our region, which is Whiteside, Lee, Ogle, north of here, Mount Carroll, that type of thing, only needed one additional behavioral health bed. And we were coming in saying we needed 10. And I think we all knew that our region needed more beds because we were sending our community members into Chicago. So we would have to go through something similar in order to open a basically an inpatient program. And I honestly haven't spent a lot of time looking at that because we were trying to partner with Patrick and trying to help them to do something separate because it makes more sense. Again, the challenges are going to be the same when you look at having a unit like that, being able to staff it with the appropriate disciplines. And those disciplines are actually housed with Mississippi. So trying to keep the experts and keep our neighbors and our family members with the experts makes sense. The other part of this is when you associate some of these departments within the hospital, there's a perception of a coldness to it, or a clinical component to this. It's a little bit more natural and more welcoming, if you will, if it's actually a different center. Reimbursement, we could talk about that till the dogs come home. The reimbursement isn't going to be there, but similar to other things, sometimes you make decisions because it's mission critical, even though you may lose money on it. But logically, it makes more sense to try to find a model for an inpatient facility that is separate from I think both of our organizations, whether it's KSB or CGH. That said, certainly both of our organizations and the other regional hospitals that are part of Project Open definitely can be strong players in the detox component of this, the medical detox component of it, to help then feed the inpatient program that our community really does need. One other thing, too, that I wanted to add to this, it's separate from the payer-related things, and it's something we also found with the behavioral health unit planning, is that there are patients and community members and neighbors and friends and family in this community that do not want to leave our community for treatment and care. And so therefore they will forego treatment, they'll forego recovery because of obligations here in town, in the county, in their neighborhood, whether it is they are a single mother, single father, and they have a child to look after. And so they will forego treatment in Chicago or the Quad Cities or where have you, because they don't have the means to care for that child locally. Or they have a family member that's sick and they don't want to leave town, or no one can come visit them if they leave town. So there's other geographical challenges to this that are barriers to individuals reaching out wanting recovery services. And I think that needs to be, stated.
I would, when we're talking about treatment and post-COVID era, we'd be remiss to not bring up telehealth. And so you bring up geographic limitations and geographic barriers. Does telehealth have a role in bridging some of that challenge or barrier?
I defer to Patrick on this one. Maybe. We're talking about partially telehealth. We found through the pandemic that telehealth is hugely effective for certain individuals that we serve. As we talk about residential treatment, obviously there are limits, right? The intensity of telehealth service can't provide what we're talking about today, but it can be a critical piece of ongoing treatment. Interestingly, I mentioned Division of Alcohol and Substance Abuse earlier. Now they're super substance use prevention and recovery. And under the super rule, historically, substance abuse services couldn't be provided by video conferencing and really couldn't even be supported by telephonic services. During the pandemic, they've opened up exceptions to that. And part of what we're looking at for rule changes going into the future is to allow those video services. And John, I remember we were talking about the jail at one point. Why can't we just do video substance abuse services in the jail? Because I can't do that. But I think we've seen some of these successes in the pandemic, and my hope is that those changes to the rules will be carried after the public health emergency.
Thank you for speaking on that. I know telehealth has become a hot topic. Either you love it or you hate it, but it's here to stay. So thanks for kind of helping our viewers and listeners bridge the gap between detox and telehealth. If it's all right with the group, I kind of want to just move to what the future might look like. What are next steps? What are we doing? And what, John, you mentioned it earlier. What's the work that's still to be done in your mind? What do you see as the next critical mission steps?
Well, I think they mentioned, the recovery homes and the geographic challenges that we have right now, the financial end of this thing. But I think we're chipping away at some of this, and we're going to continue to do that. I think the most important thing that we've talked about today is the partnerships and the coalitions that we formed, so we can educate one another and then work together to try to accomplish some of these problems locally. Because we know at times, if we do get any help from the state or the federal government, it's long term. It's a ways away, but our folks need help now. And so I'm really happy to be part of this group that was formed, back in 2015, moving forward with some of the things we did. I'm very proud of what we've done, but like you said, we've got a lot more work to do. You did mention Sauk Valley Voices of Recovery. So that's another group that's come on board with us. And, when we're talking about travel, and taking those folks to treatment that have to go to the Quad Cities, Bloomington, Rockford, and Chicago. We used to do that transportation. So they're going with a deputy or a police officer to the treatment centers. Now we've had good conversations. Again, it's a good trust building avenue, 2 hours one way, 2 hours back. But now we've got those folks from the Voices of Recovery that are helping us in the transportation of these services. These folks are very familiar with what those that are going to the treatment facilities are about to go through. On their way to that facility, they can talk to them, they can tell them about their experience, what you're going to do when you leave, and how I'm going to be there to help you. And they'll always have somebody just a phone call away, or somebody to come and visit and talk about what they're going through. I think that's a very important point to their recovery and to help us bridge some of the geographical challenges that we have, as long as we've got someone from our team with them from point A to point Z.
Thank you for that. Christy, Patrick, any next steps from your standpoint?
I'll let Patrick end. I'll jump in quick because he's so, he'll have something really profound to say towards the end here. I mean that in all honesty. But anyways, what I wanted to kind of share is I think our strategic partnerships are really what is going to propel us forward and help us as communities that we are sharing each other's knowledge, sharing each other's wins, lessons learned. Obviously the grant funding is significant because we are all being faced with other types of challenges that sometimes prevent us from starting creative programming. Having someone like you, Akil, who's really kind of championing all of us and herding us together so that we can work together and move things forward. As far as next steps from a medical treatment perspective, I think we will continue along with KSB and the other hospitals in the partnership to continue to move forward on how do we formalize those detox programs to help really strengthen that referral process and set individuals in our community up for success. The other thing that I think we have an opportunity for, if we don't have our own inpatient treatment center, that we really try to reach out and formalize those referrals back to our community so that people aren't lost to follow-up, so that we can ensure their success in the long term, whether that is getting the Voices Recovery, getting them back into our community and connected with Voices of Recovery or some of our agencies. Because what I found is that once they get to that facility outside of our community, they're not equipped with the resources to refer them back. And so we have an opportunity to strengthen those communications cycles.
Yeah, well said, John and Christy. We have done so much, and I appreciate the overview of what we've done historically and the gaps that we've filled. We've come a huge long way, and although we don't have that residential treatment center here in our area, we've done a great job of pulling together resources. Sauk Valley Voices of Recovery has done an incredible job of stepping up just as a community organization to say we'll help get people to treatment wherever that treatment is. Although that has worked wonderfully, I think the question that we're grappling with is that sustainable in the long term? Or do we really need to begin thinking more about that residential treatment center in our area of the world? And I think the answer is probably that at some point we're going to need to build it because the resources that it takes to get people out to treatment elsewhere are just going to be too taxing. And so, I think we bring the partners back together. We talk about the barriers and the challenges that exist to getting there at the moment, whether it's the finances, the payer mix, the IMD exclusion, all of that. Some of it may need some advocacy with our elected officials down in Springfield and in Washington to help support getting it done in our area. But those aren't insurmountable tasks. And so I think, we get together, we use our collective wisdom, as Christy and John talked about, get some great people around the table and figure out how to get this thing done. And I think that there are going to be opportunities in the future where we're going to be looking to the rest of you in our community to talk about how do we make this a reality for the Sauk Valley area.
Thank you, Patrick. Again, I just want to thank each and every one of you. You guys have incredibly busy schedules, but you are thought leaders in your area, and your time was very valuable today. The message you mentioned there towards the end, Patrick, is these are not insurmountable challenges, right? The advocacy at the state level is happening. Many, many years ago, there was no reimbursement for some of the activities we have for today in this space. And in a few years from now, we'll be looking back saying it was because of the work and the conversations that we had today that helped lead to some of those changes. And so there are a lot of people working. So for those listening today who may think that, there's no light at the end of the tunnel, there is. A lot of people are driving towards that. They're working towards that. We heard from 3 of the Tri-County leaders and experts here today. Again, just want to thank each and every one of you for joining. You can find this, I hope you found this talk helpful. Next week, we'll be having a talk about embracing stigma and clinical humility in the workplace. We'll have a thought leader from North Carolina joining us. And so, again, thank you, Christy. Thank you, John. Thank you, Patrick. Guys, reach out to theprojectopen.com and send any questions, comments. Follow us on Facebook or YouTube. These guys are available, part of the consortium, working day in and day out to make this community a better place. And again, thank you, and thank you for listening today. I hope you all have a wonderful rest of your Tuesday. Bye-bye.
Thanks, Akil.
Thank you.